from the Physicians Advisory Group. Public Health to be on. We'll do breakfast with the mayors and kind of a law enforcement thing with Sergeant Tapau and Major Uggan from DLC, and then Bear from Show You Roll will come on and kind of check in from Cali. 6:34. Let's go to the KUM News Zoom room where Dr. Peter Lombard is standing by. And Doc, so we brought you on, I think it was last week, to talk about the danger of the screens, which is kind of like what you do as your job. And now we're back to bringing you on to talk about COVID stats. And so I just we'll start. Well, good morning, first of all.
Well, good morning, Chris. Good morning, Sabrina and Jason.
Good morning.
What are the numbers telling you, Doc?
Well, I think a lot of people are seeing at least the huge numbers we were seeing a week or so ago. We're not seeing those kind of numbers over the hundreds anymore. That's a good indication that we're sort of turning the corner here for this most recent surge, at least. So that's the good news. I mean, the numbers are still pretty high. Yesterday, I'm just trying to look at them this morning, actually. As you guys know, the DLS was not able to report any tests, so we had a big number of those. So if you even if you sort of distribute those out over the past few days, I think it's still pretty clear that we're coming down a little bit. I think our 7-day average is still around 60 to 70 cases per day, though, which is still a ton. If you figure maybe about 10% of those will be admitted, then we're looking at admitting 5 to 7 a day. We have to be discharging the same amount in order to keep our hospital numbers the same, and that may indeed be possible. So this is a good milestone. It's still a lot, and we're still going to see some people die probably. So it's certainly not out of the woods, but the PCOR measures are certainly having an effect now.
Doc, what do you make of the testing positivity rate, though? Because I mean, like you said, we're not getting 117 or whatever we had last week, but we're getting that 10%, 11% testing positivity rate.
Yeah, that's a good point. I mean, if they were doing an extra 200 cases a day, that would mean an extra 20 cases potentially, but probably even less, because if they expanded the testing a little bit more, did more community testing, then you probably figure also a lot more of those are going to be asymptomatic or mild symptoms, or I think in that group of tests you would see a decreased positivity rate. So overall, I think you would add some additional tests, but even so, I think it would still show that our overall numbers are going down. And with the stay-home order, there's no way it can't work if enough people are doing it, and I think we're starting to see that finally. But it's really going to take it would take a few more weeks of this before things went down to the levels that we were seeing before.
What are you hearing with what's happening over at the Guam Memorial Hospital? I was just looking at this latest report with 9 people in ICU. I think it's 45 hospitalized. We've got a team that should be here from the military. We have 32 doctors and nurses and other employees at GMH that have contracted COVID, and we have a suspected nosocomial infection under investigation at GMH. How would you describe the state of our hospital?
I think if you look at other hospitals, it's instructive too, and you'll see reports and studies where they look at this, and they see anywhere from 5% up to 20% of hospital workers can be infected by COVID. And it won't always be entirely clear if they get it from in the hospital or from home, but still, it's at least a useful number to try to compare to what we're seeing here. So I think it's not surprising. It's something that you have to be almost anticipating and doing everything you possibly can to try to keep the numbers as low as possible. Presumably they've got their procedures in place, and as soon as they started to see a few cases, they try to tighten things up. But to some degree, perhaps they're doing all they can. Perhaps there's more things that they could do. I assume that they're doing an investigation with every person that's positive to try to figure out where were the links in the chain that allowed their hospital workers to become infected. There's just a lot of people with COVID in the hospital right now, and just from a patient perspective, and a lot of them are very, very sick. And the ones that are more severely sick and intubated, these are the ones that are probably shedding the most virus. So those are the frontliners that are definitely at more risk. But it's amazing to, I've seen some of them as patients, and to hear their stories, and very brave what they're doing, going in every day, knowing that they're putting themselves at risk. Some of them even older, in the older age cohorts. Mm-hmm. So that's the concerning part. I mean, our numbers are high enough that even though most of our cases are still in the lower age groups, we're getting more people in the upper age groups now. I was able to do a bit of an age analysis, and it looked like the first week of August, the percentage of patients, positive cases that we had in the age group of 60 and older was less than 5% or so. And last week, it looked like it was over 10%, maybe even 12%. And if you just go by numbers, last week alone we had 60 people, almost 60 people over age 60, and that it was three in their 90s, and 5 in their 80s, and 13 in their 70s. And there's very good detailed reports out now about what the fatality rate is per age group, because you can't just it's tough to just throw a single number out there and say, here's what your chances of dying are if you get COVID, because somebody that's 20 that gets it versus somebody that's 80 is wildly different. We know 1 out of 10 people in their 90s and 1 out of 25 people in their 70s, statistically will pass away. So just doing a real, my own, again, non-official calculations for the past few weeks based on the numbers of people we've had over 60 and applying a very age-specific fatality rate to them. It would have predicted about 4 deaths by this weekend, and we've already had 8 now, and it predicted another 11 by the end of next week. So I think that I think we definitely have more fatalities coming, and even if our numbers stay in the 50 range, which is good hopefully from a hospital maintenance standpoint, we're still certainly going to see more deaths, and it shouldn't be surprising. And I'm sure they're doing all they can over there, and it's just it's probably coming, and that's a sad reality.
Gee, thanks.
Yeah, thanks for that, Doc. Sorry, I want to go back to the nosocomial infections. I mean, at this point, sometimes you can only laugh. I don't know why we're laughing after hearing that, but going back to the nosocomial infections, Doc, at what point when we have these 32 cases, is there a point where we got to look at like, hey, what are our measures? Because when we talk to Lillian, we hear things like, oh, they have a COVID section in the ICU that's pretty much a plastic curtain, and we read in the Army Corps Engineers assessment of GMH that there are problems with the ventilation system. So and just seeing like that number 32 infected hospital staff.
Right. And that's, it was 12, right, during the first wave.
Right.
So you would think, okay, there's something going on, but, it may or may not be related to conditions.
Yeah, it's kind of one of those situations where if we're not sitting at the table, if we're not one of the people helping to plan the investigation into why this happened, I think it's hard for us to be able to know for sure. Yeah. Is there something intrinsically wrong with GMH that it would be beneficial for us to think of some other option for them? It'd be nice to get somebody else from GMH, if one of the ICU docs or something to come and speak to that. It would be, I think, useful.
Right.
What do you think, though, about the whole debate of we should move the non-COVID patients out of GMH?
Yeah, I feel like it's the same thing. Like you're not sitting at the table. You weren't there when they went through their analysis and had the pros and cons for moving. And I'm sure the list is pretty long of reasons why a move wouldn't make sense. And it'd be great to see that list just from our perspective, because we would have a better understanding of their reluctance to do something like that. I just think there's a lot of reasons why that I just don't know.
Right.
But again, we're just kind of trusting the people at the table are making the best decision, and we hope that's the case. But all along, I've heard them still say, all these options are still possible, and that they're willing to consider them. So that's good. I think they are showing an open mind. Dr. Nguyen has always said that as well. So At some point if the evidence becomes overwhelming that, GMH is not a safe place, or that maybe we'd have a little bit more success controlling things like nosocomial infections at another facility, and perhaps that they would reconsider. But probably have a lot of difficulties and challenges to overcome to make that happen, and we just don't know what those things are.
We're just letting that sink in for a minute, Doc. Wow, so I mean, you're laying it down pretty heavy here.
With which part?
Well,
The
just the
fatality
fatalities
rate.
and
Yeah.
yeah.
Oh yeah. Well, hey, it's if it's hard again. It's hard to look at the numbers of people that are over 60, but they give the age report. It's a cumulative, so you kind of have to really keep track each week or each day almost, and see which numbers are changing in which age group. But it's 30 people over 60. Or 60 people over 60. That's a lot.
Yeah.
And if you look at the last 3 weeks, and it is what it is. And then you add more comorbidities in there, and we may end up doing better than that, and that's certainly hopeful. But that's just it is what the numbers are
Right,
predicting.
Yeah. And I think that's what's alarming for us, is because we've folded you into this COVID conversation for months now, and I think you're reasonable, right? You don't have alarmist tendencies, and so to hear you kind of coming from your detached, I'm looking at these numbers and this is what I see, and we're definitely going to get more fatalities. Brace yourselves.
Mm-hmm. Yeah, we know that and the reason why we haven't seen them yet, I think, and I hope is the average time from symptom onset to death is 23 days, and this is from looking at thousands and thousands of cases all over the world. So 23 days. So you really have to look back, 3 weeks from now to see the numbers where our numbers were really, really high, and those are the deaths we're seeing now. So even if we see a pretty big handful of deaths over the next week, we're not done yet. We're still, where the curve is still hopefully starting to come down and coming down. But, as long as we still are picking up cases in their 60s, 70s, 80s, and 90s, unfortunately, we're still going to have more people succumb to the COVID disease.
Mm-hmm.
What are your thoughts on the community mass testing? So, people have been clamoring for this. Public health said, man, we don't have the resources to go out and test 1,000 people. We saw this tremendous, almost a 2-week backlog where people got tested and they didn't get the results till, like I said, 9, 10, 11, 12 days later. And so now we're hearing,
you've got to have. Mm-hmm.
Now we're hearing they're going to do a mass testing in Talafofo. That's this weekend?
This Saturday. Tomorrow.
Yeah.
Tomorrow.
But it's limited to the first 200.
Yeah,
people.
you had to have registered.
Oh, wow.
For it.
Yeah, and it's already full. And so I'm just seeing in my mind, people hear mass testing, they're going to show up, they're going to think they can get tested, and then the whole, why are we only testing 200 people is going to start.
Yeah, well, that's
nuts, right, Doc? That's kind of nuts for people at Talafofo. What? They're doing a mass testing? What? It's already full?
Yeah. And I mean, that was the press release. There wasn't. I don't even remember seeing a press release saying that, hey, if you wanted to go to community testing, then call your Talafofo mayor.
It was actually Mayor Doris Lohan on our show who just mentioned it anecdotally, and all of us were like, whoa.
Right,
yeah. No one knew.
Wow.
So sorry.
Yeah, no, I
hadn't
heard that.
By the way, Doris
they've
is
got to
the
have
mayor of
the
Talafofo.
facilities available on the testing.
They're on.
So what are your thoughts on that, Doc? Do we need to do more community testing, less?
Well, the idea is to identify every single positive we can, because once you know, then you can not only isolate, but then you can also start to look at your close contacts and get them tested. But if you just can't test them fast enough, then I think that it's this probably more harmful if you can't run the samples fast enough. But in general, the principle of testing more people is always going to be better. I think we see that in many different places all over the world. So I'm an advocate of that if we have the capability to do so. And I do think that we're going to see a bit of a change in terms of once these new tests come out, these more rapid tests that are more inexpensive. I think over the hopefully next month, we're going to start to see some of these rapid tests become more available that are FDA or EUA approved, and that's going to really kind of change the whole testing game.
Well, Doc, we're waiting for the official announcement to be made by Adelup about the likelihood or that this PCOR 1 will be extended. You agree that that needs to be done considering the numbers we've been seeing this past week?
Well, I'll say this: when we first went into PCOR 1, I think I was a little bit I thought it was a little bit too strict, and what I wasn't expecting was how rapid our numbers increased. It wasn't just this kind of slow rise; it was just immediately just boom, and we were seeing numbers in the hundreds, which was pretty sobering. And then in retrospect, you feel like, wow, that was a pretty good decision. We'll never know if some other plan could have worked, and we'll never know what differences we would have seen if we did sort of a modified PCOR 1 that was a little bit tighter or a little bit looser, or PCOR 2 that was a little bit stricter. But I think we're lucky that it is what it is, because I don't think our numbers would have come down quite as fast if we had any other measure. But what's enough? I think not only are we had this order in place, but also people started to see more people getting sick in the hospital and dying. And now it's hard to find somebody in Guam who doesn't know somebody who either has had COVID, or everybody knows who the governor is. And so, but then not only that, but there's usually some personal. There's a personal. I think it's affecting people more personally now because they know of somebody that's been sick, or maybe who has even passed away. So as that happens, the fear increases, and then people start changing their behaviors, regardless of what the mandates are telling us to do at any given time. And I've always been more. I try to be more balanced. I do think it's possible to open up more business, because I just don't think that the businesses are the drivers of the community spread. It's just to some degree, and maybe certain businesses, yes, but most businesses, I would love to see them open as long as adequate protections are in place. I'd like to see that happen.
All right. Thank you so much, Doc.
Yeah, thanks. Thanks for the downer.
Sorry, happy Friday.
Yeah, there you go. Good save.
Well, stay safe.
Hey, you're all going to die, but it's Friday, guys. Okay, Doc. Appreciate it. Yeah, be safe, okay? Wash your hands.
Okay.
Thanks,
guys. Bye-bye.
Okay, bye.
Dr. Peter Lombard. Sorry, guys. We're a little dark.
Happy Friday. Oh, dang.
Oh, boy. I think we need to take a break, okay? We're coming back with Crystal Pacos and Augustine, the Adelu press secretary, who's going to give us a little bit of a heads up about what could be announced at the governor's press conference at 11 o'clock